Well, I would say good morning. I would say my expertise is vascular anesthesia and occasionally regional anesthesia, but no orthopod wants to see me. So I have changed the slides a little bit. I will upload them to this website, vascularanesthesia.com, if anyone wants it. It's not a commercial website, it's got .com, but it's just got lecture notes and things like that. So if anyone wants to download it after, I'll upload the slides there, and as well as the lecture that I gave yesterday. Thank you, Dr. Reese, for inviting me here. As I've told a number of people, my grandmother used to live at 254A Ashley Avenue, and so this is an area that's near and dear to me. Conflicts of interest, I do work with Baxter. They make volatile anesthetics. I will make a few comments about volatile anesthetics. So you may or may not believe what I believe, but hopefully at least believe that I believe what I say. And so that's that conflict of interest statement. I've just, to frame this, I've just stolen a couple of slides for the European Stroke Society to look at guidelines to sort of foreshadow the overall or overarching issues in carotid artery surgery. So I've stolen them, freely admit them. They're a couple of years old. And it's very interesting. Yesterday we talked about the difference between American and European guidelines. You see a little bit different here, but important to point out. Number one, carotid endarterectomy reduces risk of disabling stroke by 48% in patients with 70 to 90% stenosis in NASIT. NASIT, North American Symptomatic Carotid Endarterectomy Trial. Symptomatic. Okay, symptomatic patients. This was done in 1991. All right, and one of the issues that we'll mention is whether or not this is still relevant, given the fact that medical treatment has changed a lot in 20 years. If perioperative complications exceed 6%, the benefits of carotid diminish. If they approach 10%, there's no benefit. And so I think that the benefits of carotid depend on your local results. All right. CEA should be performed as soon as possible after the last stroke or TIA. There's been some debate about this over time. Whether or not you do people, on the day of, probably not ideal. This is something that people debated over time. You see here that the number needed to treat, just to put things into perspective, we often think that we're doing things that are very helpful for patients. In general, asymptomatic stenosis can be treated with carotids, but in the ACAS study, the asymptomatic study, you see the number needed to treat to prevent one stroke per year is huge. And that's why, whereas you will see recommendations to do carotid endarterectomy in the US, and certain vascular surgeons have done research to say, well, if we look at plaque morphology on an ultrasound or other predictors, we can predict relatively high-risk asymptomatic people. But the Europeans don't recommend doing asymptomatic carotids in general for this reason. You got to do roughly 100 carotids to prevent one stroke. And when you do 100 carotids, you have the opportunity for a lot of potential downsides. So therefore, whereas they say you want to have less than 6% complication rate for symptomatics, you want to have less than 3% complication rate for asymptomatics. The upside of that is that asymptomatic patients have lower event rates with carotid, probably because their disease burden is less. Once you're symptomatic, you've declared yourself to be more of a vascular path. And one of the reasons I say that NASIT may or may not be applicable now 20 years later, and it was published 20 years ago, so it means data was collected 25 years ago, is that we know that statins reduce the incidence of stroke. So if you put people on statins, right, aggressively, and no one has looked at getting LDL less than 150, and yet we know that in our cardiology patients, the goal is, with patients with coronary disease, to get them down LDLs below 100 or even below 70. So we don't know what aggressive statin reduction would do compared to surgery, as well as antiplatelet therapy. We know that antiplatelet therapy may reduce the risk of stroke in certain groups. So if you combine those two, there may be some benefits. If you look at the European guidelines, they basically recommend that patients should receive antithrombotic therapy. Where possible, that would be aspirin and dipyridamole or Plavix alone, or aspirin alone. And so these patients should come, when they come to surgery for carotid repair, taking at least aspirin. And they should continue that through, not only to reduce cardiovascular complications, but it's been shown that those patients have fewer cerebrovascular complications as well. Now the challenges with antiplatelet therapy is that you end up with this occasionally. So before we had patients routinely taking antiplatelet therapy, this was not a problem that we saw. Now, this guy was not easy to intubate the first time, okay? This guy was not easy to intubate the first time. Now you get a hematoma, and whereas the teaching is that the issues there are relieved by opening the wound, that is only partly the case. It actually turns out these patients also tend to get a fair amount of edema. And I don't know how many of you have dealt with a wound hematoma trying to do a fiber optic intubation in these patients. They end up very edematous. So it's not just you open the wound, that's the teaching, and everything is fine. Right? This guy was difficult beforehand. He's going to be exceedingly difficult afterwards. And there's a series from Toronto that shows that after going to routine antiplatelet therapy, the amount of wound hematoma went up significantly. And it was particularly problematic for patients who were left intubated. Because imagine patients left intubated, they occasionally cough after surgery. It's even worse. So now, what about carotid artery surgery and angioplasty? Again, these are European guidelines. So they're recommending that patients not get asymptomatic work done. European guidelines different. And here, this is 2008, they're recommending that stenting not be done. Why were they recommending that stenting not be done? That's because many series had shown that the stroke rates were higher. This is 2008. I'll show you some recent data towards the end that suggests that stenting may be becoming more comparable to carotid endarterectomy. So in 2008, the Europeans are saying, don't do asymptomatics, don't do stentings, and continue aspirin before carotid. All right. Now, why is it that we see more recommendations for stenting? Because we have studies like Sapphire that came out that showed, and they showed huge differences. Others have not shown such large differences at all. I think in general, carotid endarterectomy is still probably superior or equivalent, but they showed differences. The thing is that they use these embolic protection devices. And the big problem with carotid stenting is you blow up the balloon, you put a stent in, but you have all the stuff that goes distally. So this is essentially an umbrella. There are various ways that one can trap clot and debris, and this seems to lessen the rate of stroke. Okay, if you do MRIs on patients after stenting without protection devices, embolic protection devices, the incidence of emboli is almost universal. I mean, it's very, very high. And CREST is most recently published back about a year ago. This is a randomized trial. When you look at outcome here between carotid endarterectomy and stenting, and this is freedom from combined endpoint, which is death, MI, stroke, you see fairly equivalent results. However, and we talked about this a little bit yesterday, if you look at what the outcomes are, the outcomes were death, MI, or stroke. With stenting, even with embolic protection devices, you had higher rates of stroke. With carotid endarterectomy, you had higher rates of MI. If you had a choice between having a stroke and an MI, which would you choose? Choose the MI, right? So one could argue that this unfairly is biased against carotid endarterectomy because it combines stroke and MI, and you've said that that's not what you would choose to do. So most of my comments are going to be anesthetic management of carotid endarterectomy, and we'll talk about stenting a little bit at the end. So one can choose two types of anesthesia, regional, general. If you look at, for example, that CREST study, which had a couple thousand patients in it, 90% of the patients got general. If you look at a study that was a survey of anesthesiologists in the neurosurgical, neuroanesthesia journal, you find about 85% use of general. So most people use general anesthesia for carotid endarterectomy. The benefits are a motionless patient. You can control hemodynamics with anesthetics. You can control the airway and CO2 should you have cerebral ischemia. The advantage is to regional. It's cheap. The anesthetic is cheap, and the monitoring is cheap. So you're not bringing someone to do EEG or you have TCD or whatever it is. Questionless postoperative hypertension and quicker recovery. So those are some relative benefits. But of course, there are different types of regional anesthesia. There's a superficial cervical plexus block. So I heard at a meeting, Terry Vitez, I'm sure he's retired these days, talk about, what I do is, I do superficial cervical blocks. So no one ever taught me how to do one. I went to the book and read it. It's easy. It's a field block, all right? And this works fairly well to provide anesthesia to patients. Now, you can basically do it two ways. One is just to give an injection here under the belly, sternocleidomastoid muscle, and or you can fan up and down. And it's my want to do both an injection here, roughly 20 cc's of, maybe 0.375% bupivacaine. Anyone ever done a wrong-sided block? Keep looking at me. Don't look at your room. Don't look at your department. Anyone ever done a wrong-sided block? No one wants to fess up. I've done a wrong-sided block here, okay? All right. Brave man back there. Thank you. Okay, 9. Don't turn around. So I will tell you I've done this. Now, I was in a discussion last week and people saying, we should be able to talk to the patient and figure out what side you're supposed to block. How many patients know for sure which side they're having done, right? So anyway, so I will admit I've done a wrong-sided block here. So, clean, you can fan. I mentioned this way. I showed you what you do here. Again, you're showing here a one injection or fan injection. This works fairly well. Now, the deep cervical plexus block, how many of you do deep cervical plexus blocks? This is, I am not proficient in doing that. There are potential side effects here. You can see intravascular injection, total spinal injection, potential side effects. And I mentioned here some of the side effects, blockade of the phrenic, recurrent laryngeal vagus. And some people do both, right? Do both a deep and superficial blockade. The folks at Michigan actually published a randomized trial where they randomized patients to deep versus superficial, and they asked surgeons to assess them. So you see here 20 patients in each group. The ages were the same. You see here surgeon rates conditions, equivalent, convert to GA. Only 1 out of 40 patients were converted to GA. Now, you have to have good patient selection. So the patient with COPD, the patient who's very anxious, the patient who's obese and can't lay flat, the patient who has a high lesion where they got to get up under there and occasionally dislocate the jaw may not be the best patients for this technique. But only 1 out of 40 converted to general. Shunting levels here, you see 5 out of 40. So that's actually just sort of about normal. Now, the advantage to deep was here, the time to first analgesia was longer. Okay, that's significant. The pain scores were lower. Okay, and that was significant. But when you ask the patients were they dissatisfied, only 1 patient in each group was dissatisfied. So from that perspective, one could argue they're equivalent. And given that it's hard to get into trouble with this and easier to get in trouble with this, for me, that's something that I'd like to do. Now, what they also found in this study is that the need for supplementation was fairly equivalent. That is, the patient that got deep blocks often needed local supplementation superficially by surgeons, and vice versa. Patients with superficial blocks often needed supplementation when they got deep by surgeons. So, but that tended to be fairly similar in both groups of patients. Now, why do people like to do awake carotids? It's because the rate of and this is not a randomized trial here, but the rate of shunting is less. And so you see here in one study, patients who had this CB cervical plexus block, they only shunted 7.5% of patients versus 17% of the patients who had GA. In part because your anesthetic effects can look like ischemia in terms of slowing the EEG. And so, you have changing anesthetic depth, you change the anesthetic, right about the time they're going to clamp, that can get confusing. I think that's one of the reasons why this may happen. So this is people who want to do the awake patient as a guide to neurologic monitoring find that you need to shunt less because, patients awake, and you see that. Now, if you ask me what my bias is that, and I've said this for a long time, and I'll present some data in a bit, that the choice of anesthetic doesn't matter, but it is also fair to say, just as there are different techniques for regional anesthesia, there are different techniques for general anesthesia as well. And I'll go through some data, some of it old, some of it newer, that looks at different choices we may make and how that impacts outcome. And it's the rationale for general anesthesia, surgeon preference. Particularly, you're an academic institution training surgeons. They're going to be slower. They're not so used to working on a patient who's cooperating with them, as it were. They'd rather the patient not cooperate. And so these are some reasons you may do that. So what are the different kinds of GA that we may provide for patients? So this is an old Australian study, and I was in China recently, and people were discussing doing things in some ways similar to this. Okay? What did they do? They monitored EEG. Did they monitor EEG to make sure the patients were not getting ischemic at the time of cross-clamping? Au contraire. They were monitoring the EEG, again, you see this is published in '94, so that they give pentothal, today you might give propofol, so that they could suppress the EEG. Okay, they wanted a flatline EEG. The idea being that you reduce CMRO2, and should you have ischemia, it's tolerable longer, and or the drug has some other intrinsic neuroprotective effects. Because they gave these patients a lot of barbiturate, most of them required some alpha agonist to maintain blood pressure. They shunted no one. So this is one approach. Okay, we shunt no one. We just suppress the EEG. You're shaking your head. All right. Here are the rates of MI and stroke. Okay, this rate of stroke is less than 2%. It's as good as anybody in the literature. In this large series is 621 patients. More than one way to skin a cat. Now, you might get into medical legal troubles here in the States with no monitoring and no shunting, right? No shunting, and when I say no monitoring in the sense that you're not looking to see who gets ischemic. So from that perspective, no ischemia monitoring, no shunting, but rate of MI 0.5%. Now, there's a meta-analysis I read once. I read it and I cannot find this reference. I have searched for hours. That basically looked at a bunch of studies of carotid endarterectomy and said the biggest predictor of stroke rate in the study was the specialty of the primary author. The primary author was a vascular surgeon. The stroke rate was about a half of what it was if the neurologist was the primary author. So again, what's a stroke sort of is in the eyes of the beholder. It ain't no stroke then. But these are good results. So you shake your head, but these are good results. I mean, I've never done this, but you see here good results. Ventilated the patients for 2 hours after surgery. I saw some similar techniques in China where patients are sedated afterwards and then awaken. What about this? How about a TIVA compared? So this is remifentanil propofol compared to isoflurane fentanyl. This is an old study from Loyola in Chicago. And you see here, now this was, they said that remifentanil propofol is more expensive. This was, again, work that was done 10 years ago before these drugs were off patent. And you see here that there was more ischemia with the isoflurane fentanyl, particularly at induction. No MIs in either group. These patients were less awake, and they were and they had more PONV. Not surprising, we know that volatile anesthetics contribute to PONV. Having said that, though, there were really no there's difference in cost. That the patients woke up faster with the TIVA, but you know, outcomes overall were no different. Nitrous oxide. How many of you use nitrous oxide routinely? Fess up. Fess up. So most people are not raising their hands. Some of you are asleep, I presume. I like nitrous oxide for carotids because we know that if you give 1 MAC with nitrous and a volatile, you get a higher blood pressure generally than if you give 1 MAC volatile. And to the extent that you're trying to keep blood pressure up for collateral perfusion when the clamp goes on, nitrous helps. Nitrous may also facilitate EEG monitoring. That is, you're using less gas if you're using gas, and you may have an EEG that's easier to monitor. Some people use EEG or SSEP. Some people use SSEP as well during carotid endarterectomy as one thing to monitor for ischemia. But I can tell you uniformly, you give people volatile and nitrous oxide for their carotid, they will vomit. You can guarantee that they will vomit in the postoperative period. Having said that, this is from Dan Cole, a review in the British Journal of Anesthesia last year, saying, you know, it's hard to put a shunt in the carotid without exposing some air to the patient, and therefore he recommends that you not use nitrous oxide. Or if you're going to use nitrous oxide, you get it turned off before clamping so that you have the nitrous out, so that if you get an air bubble in there, you don't have nitrous expanding a bubble that's going to the brain. Here's a study comparing remifentanil and DES to fentanyl and DES. So what's different here is the opiate, right? Does the opiate make a difference? Now, you see here they're giving 4 mics per kilo of fentanyl. For me, that's a lot for carotid. And so you always have to look at how these studies are done. And what they find here is that when you give Remi, you actually have lower blood pressure before intubation, lower blood pressure after intubation. And if you look at heart rate here, before cross-clamping, it's lower with Remi here than it is with fentanyl. So is that an advantage? I'm not so sure. Requires use of pump. And you see recovery times here. Everything just about as fast in terms of opening eyes. Everything from here on down is significantly faster with the patients that got remifentanil compared to fentanyl. So one might argue you can do that, but 4 mics per kilo is more than I'm used to using for carotid. Here you see again level of alertness of sedation, so the patients who got remifentanil are waking up quicker. So now, I read a series of articles that came out of Italy that describe a wake-up test. How many of you do wake-up tests for your scoliosis surgery? Or am I showing my age? Are people still do it? Okay. So the idea is you want to assess neurologic integrity. You're still doing SSEP monitoring, I presume, right? But they still want to see the patient wiggle the toes, right? Occasionally, okay. The old school surgeons, right? The old school surgeon. You got one left, okay. So similar idea here is maybe we want to wake the patient up in the middle of their general anesthetic to assess when you clamp that they have neurologic integrity. So Dr. Baldinelli gave me his permission to show his video. He published this series in 2010 in the Red Journal, and they looked at using remifentanil and propofol infusions to target site concentration, which is not something that we have in the U.S. And the bottom line is they would have patients anesthetized. When it came time to cross-clamp, they would wake them up. And what they would do is spray the tongue, spray the airway, put lidocaine in the balloon of the endotracheal tube to provide some local anesthesia so that patients could tolerate the anesthetic. So let's see if we go to the next slide. Yeah. Anyways. Try the previous slide. All right. So I do want to show this video. So can we just load up the video? And the idea here is, now how many of you would want to have your carotid done with a tube in when you wake up for a bit? Here, we'll show the...
Oh, you need to put the marker down.
Put the marker down. Okay, here we go. Who speaks German? So you see, they're no gloves. This is terrible. No gloves. This is terrible. Lips getting bruised. Nice and bradycardic from that Remi. So that's the Remi. Mechanical ventilation. So now they're going to reduce the levels of infusion in a bit. There he is. So this is northern Italy, so they're speaking German to him near the border. See, they got the cerebral oximetry on him too, so they don't trust the fact that he's awake, okay? This is maximal monitoring. Like a peanut coming out of the shell. And then once they're happy with this, they actually will put him back to sleep for the rest of the procedure. And part of the reason they did this is because their surgeons did not want to do this without the patient awake. So no one here said that this is something they wanted to do. When I showed this at the SCA a couple of months ago, no one agreed that this is something that they would want to do. But the question is this worse than just having a carotid under regional? You say, well, yeah, because you got a tube in. But again, there's some REMI, there's some propofol on board, and patients didn't complain of this at all. So let's go back to our presentation here. Okay. All right. So that's a combined technique that we see here. And one of the reasons they did this was because in their experience, they had found, as I mentioned before, in patients who had cervical plexus blocks, a lot of them needed supplemental local anesthesia, 66% needed sedation. There was a reasonable conversion rate to GA, so their idea was just, let's go ahead and put these patients to sleep. And so they looked at this and did a randomized study, actually, of patients getting TIVA, getting a regional block or a reasonable block plus a TIVA. Okay? And again, they did this. There was no GA control group because the surgeons did not want to operate on patients that they couldn't assess neurologically by intact, squeeze the thing, stick your tongue out kind of function. And if you look here, the comparison in terms of comfort and sedation, the patient comfort and analgesia, the patients who had the regional plus general rated their experience more comfortable, less pain. The other thing that was interesting, the patients that had the combined general regional had lower blood pressures at the time of cross clamp and at the time of unclamping. And the question is this a good or a bad thing? A lot of us have liked to raise blood pressure at the time of clamping to provide collateral perfusion. You see here, not surprisingly, lower blood pressures with the combined techniques. And one would ask, is this a good, they say this is an advantage. I would question whether or not this is an advantage. On the other hand, I would say from the point of view of the issue of neck hematomas, having hypertension after surgery is probably not a good thing. And these are patients who can certainly develop explosive hypertension after surgery. So my approach has been to put these patients to sleep, do a superficial cervical plexus block, get that analgesia, and then be able to run them on 50 mics of fentanyl. So smaller mics than the 4 mics per kilo that was in that comparison of fentanyl to remifentanil. And it is my experience, I don't have data, that those patients have less postoperative hypertension because their analgesia is assured. But the question is, at the time of carotid clamping, so in the PACU, lower blood pressure, probably useful to limit bleeding, limit myocardial ischemia, et cetera. But at the time of cross clamp, you probably want a higher blood pressure. Maybe you do, maybe you don't. A survey that was published in the neurosurgical neuroanesthesia literature showed most anesthesiologists augment blood pressure. It allows one to lighten the general anesthetic. Often use alpha agonists. They have little effect on cerebral vasculature, may increase the work of the heart, may produce myocardial ischemia. So here's an old case of mine where we're getting the blood pressure up around the time of cross clamping by going down very low. This is 70% nitrous, going down very low. And despite what Dan Cole said I should do, I still got the nitrous going very low on the amount of volatile anesthetic here and getting the blood pressure up that way. Why do it this way? Well, one is this patient had EEG monitoring, so I have some sense whether or not the patient is asleep or not. That's number one. Number two, why not just give vasopressor? Well, the other question is before I get to the vasopressor, is should we really even be raising blood pressure? I certainly had the experience of seeing patients clamp, blood pressure's on the low side, EEG gets ischemic, you give them vasopressor, get the blood pressure up, the EEG normalizes. But if you ask, is that why patients have stroke after carotid endarterectomy? It is usually not the reason. Okay? You see, the biggest, so cerebral ischemia here, this is essentially something that one would think, this is a retrospective study looking at surgeons doing sort of quality assurance, looking at what they think the causes of strokes in their patients were. You see here, what does this look like? 20% maybe of the patients had strokes because they got ischemic. And some of that may also be related to, and some, some of these may be shunt-related issues. But you see here the most common, or at least the plurality of problems are related to post-op embolus and post-op thrombosis. That has nothing to do with blood pressure management during the time of clamping. Some unrelated to the operated artery. Who's seen that? We know that patients, because now you expose the baroreceptors to higher blood pressure, can respond after carotid, either stenting, you see this a lot with stenting, or endarterectomy, respond with a vagal response. So you get hypotension and bradycardia. Okay, after you remove the plaque. Baroreceptors take a while to get back to normal. So all of a sudden you get a patient that gets hypotensive, and I've seen people in PACU who have ischemia related to the unoperated artery because they got hypotensive. Anyone seen this? It can happen. And so you see this here that, there was about as much of that ischemia unrelated to the operated artery as there was relative to what was happening in the OR. So, we get, concerned about maintaining blood pressure at the time of clamping, but realize that when the patient has a stroke, it is more likely to hit intracranial bleed, surgery related. So, we're responsible for a minority of intraoperative strokes with carotid endarterectomy. What's this here? Where are these ladies at? What would you call where are they? What is it called? A ball. Another word? Gala, right. So gala. All right. So gala, a long time people debated, right, whether or not regional versus general was better. And finally, some folks from Great Britain actually did a study where they randomized 3,500 patients. For years, people had written that the event rates are so low, right, that you'd need to do a very large study to adequately power to look for differences. And these were both symptomatic or asymptomatic patients. These patients had open surgery with either local or general. About 90% of them got general. Okay, looking at practice patterns, done in a lot of hospitals in multiple countries. And when you see here stroke or death, the odds ratio favors regional, except that the 95% confidence interval crosses, I better stop using this, 95% confidence interval crosses 1. That is, this was not statistically different. This was a bunch of other studies. This was a meta-analysis without GALA. When they add GALA, you see here, it is not significant. Okay, so this would say it does not matter what anesthetic technique you use. If you look here, events occurring in the first 30 days, if you want to look at the numbers here, they're very equivalent, okay, general versus regional. The one thing they found is, again, not surprising, less shunting with regional, because you're only shunting when the patient doesn't have neurologic integrity. Part of the reason the shunting is so high here is sometimes it's for neurologic deterioration, but you see a lot of places where they just routinely shunt it. So you have some surgeons that shunt selectively based on monitoring, shunt selectively based on stump pressure, the back pressure when you clamp, some who shunt based on TCD or contralateral occlusion, blah, blah, blah. So the reason, in part, that shunting was so much higher in the GA group was just because there were a large number of surgeons that would just shunt everybody. And now shunts make you feel good, but you can have, as I mentioned, air emboli, other embolic complications of placing shunts. So they're not a free option, as it were. They come with a certain cost. You see here there's less need for blood pressure manipulation in terms of treating hypertension, so less need to treat hypertension with regional, but look at this, more need to treat hypertension. So, I'm sorry. So you see here that, less need to get the blood pressure, let's get this straight here. More need to get the blood pressure up with GA, less to get it down with GA. You see, again, if you look at those patients that needed no manipulation, that was more likely to happen than patients who had a local anesthetic. This is one of my old colleagues. I think, I mentioned when you looked at that pie chart of why strokes happen, okay, you can talk about all the techniques for monitoring, anesthetic technique, I think the person who's doing the operation or the proceduralist is probably the most important thing here. And you get a sense of that in Gala, as there was a suggestion that trainee surgeons and anesthetists, they call them there, had better results with general anesthesia, although it was not significant. But there's the sense there that people starting out do better when they have a motionless patient, that they can feel like they can take their time and they're not rushing, et cetera, et cetera. Then the people who published Gala published a subsequent article that suggested that local anesthesia was more cost-effective, and that has to do with the fact that you're not using as much drugs, and you're not spending money on monitoring, and you're doing less shunting. So those are some of their potential cost benefits of local anesthesia. So but they summarize, they say in their work, no compelling advantage has been demonstrated with any anesthetic technique. Therefore, this should, do what you think is best. Realize that general anesthesia is useful for people with abnormal anatomy or pathology. So someone that has a high-up lesion, someone that has a radiated neck, et cetera, there may be patients who are specifically suited, or the obese patient, the COPD patient, may be more suitable for general anesthesia. Lastly, I'll steal a few more slides or summarize some information. Again, I would recommend, this is in the BJA last year. Dan Cole, Kristen Erickson from the Mayo Clinic wrote a nice review on carotid disease, stenting versus endarterectomy. And they would summarize, and this is these are my summary slides here for this talk, that as far as anesthetic technique, there's no proven advantage for a single technique. However, they say that nitrous oxide should be discontinued if you're going to use a shunt. And of course, it's always difficult to predict when you're going to use a shunt until you actually clamp the carotid. I've mentioned, for example, that remifentanil may have some advantages as far as waking up as compared to other opiates. I actually like combining regional and general, not with a wake-up. That patient had a wake-up, no wake-up, neuromonitoring, but having a superficial cervical plexus flap for post-op analgesia. Carotid stenting and angioplasty, minimal sedation, heparin, ACT management, antiplatelet therapy is certainly important in both groups, but particularly important here. Now, remember, these patients can become extremely bradycardic, okay, at the time that they get the balloon blown up. And can continue to have bradycardia and hypotension, have that vagal response after surgery. So this is something that one needs to be prepared for, the potential for severe bradycardia at that time. Then as far as cerebral monitoring, they state that either the neurologic status in the awake patient or EEG may be close to a gold standard. And they suggest that transcranial Doppler, which we've not talked about here much, has the potential advantage of being able to detect cerebral emboli. And actually, if you put TCD on patients, you probably should continue it into the PACU, because what you see is the first hour after the repair is when the rate of microemboli is actually highest. The rate of microemboli is actually highest in the first hour after surgery, as you have clot forming on this freshly repaired artery, despite the antiplatelet therapy and the like. And obviously, or presumably, the patients who are having angioplasty and stenting are awake, and so that is their monitoring is neurologic status. And essentially, what you're trading off here is very transient ischemia when you blow up a balloon versus increased embolic risk. Here you have longer periods of ischemia, and yet or potential ischemia, depending on your collateral circulation around the circle of Willis, and yet it seems like still today, if anything, the stroke rates are lower. Post-op concerns in both groups, hemodynamic stability, more myocardial ischemia with carotid endarterectomy compared to stenting. Hyperperfusion syndrome. Anyone see hyperperfusion syndrome? Patients can get, this can progress to frank seizure. You have someone that has had a tight lesion, and suddenly you open that up, and now they're getting a lot more cerebral blood flow than they used to receive. One of the things that you will see contributes, patients will complain of headache, and that's something, if you have a patient who has complaints of headache, particularly unilateral headache, not like his neck ache there, but headache, that can be a sign of hyperperfusion syndrome. Occasionally those patients can stroke. Myocardial ischemia can also occur in patients undergoing angioplasty, particularly if they get hypotensive. Jim McKinsey's an old colleague of mine who's at Columbia, and they actually published some of their retrospective work looking at which patients tend to become hypotensive and require vasopressor support after carotid angioplasty and stenting. And they particularly looked at people that needed 1 to 24 hours of vasopressor support and those that needed even more. And we see the patients who needed more than 24 hours of vasopressor support, relatively small group of patients. You see here that more often they were older, they were female, and you see here that they were more likely to have intraprocedural hypotension, bradycardia, and require vasopressors. So the patient who gets hypotension, and you see this with carotid endarterectomy, when they open the carotid, if the patient's blood pressure drops, say more than 30, it's normal to see a blood pressure drop about 10% when they open the carotid. You see a patient's blood pressure drop by more than 30% when the carotid's open, it is my experience that those are the patients who are likely to continue to be hypotensive. That baroreceptor's now seeing higher pressure and responds to the vagal response. And this is something that you see most patients get over in 24 hours, but occasionally you see patients who take longer. The women, the older patients, and the patients that you see intraprocedurally get hypotensive bradycardic or require vasopressors. So I want to thank you for spending time with me, and I always think it's better that I end 2 minutes or 3 minutes early than go overtime. And I will put up this on this website here. This is actually an old version of the slides at the SCA, and I updated them a little bit for this talk, but I'll post the slides there if anyone wants to download them. I thank you very much for your attention, and thank you, Dr. Rees, for inviting me. Mm-hmm.
We used to be taught that it was better to lower a patient undergoing GA,
right,
to lower your volatile anesthetic in order to raise the blood pressure,
right,
endogenous catechol,
right,
versus giving an alpha agent,
right,
for decreasing risk of perioperative MI.
Yeah, let me, somehow I managed to hide that slide because I'm actually a co-author of that study, so you might as well give yourself credit for work you've done. All right. So here's the so we were taught based on this study that I'm a co-author of. So how was this? The study was done was looking at using phenylephrine for carotid. Patients randomized to isohalothane. It shows you how old the study was. Didn't really matter what the gas was. And they were randomized to, as you say, light anesthesia, turn the gas down, as in the example I showed, all right, and let the blood pressure come up, versus phenylephrine. And this was early TEE, and what you see is wall stress goes up with phenylephrine, but not light anesthesia. In point of fact, phenylephrine is a pure alpha agonist, okay? And, Gertz has shown that when you give phenylephrine, you look at echo, you dilate the heart. So yes, the blood pressure goes up because you're giving an alpha agonist, but the heart actually goes into mild failure, and your cardiac output either stays the same or goes down. In a way, light anesthesia is more like giving norepinephrine. And if you look at what norepinephrine does, if you give exogenous norepinephrine, you see because you have some beta, you don't get the cardiac dilatation that you get with phenylephrine, so that you maintain, blood pressure goes up and you're maintaining cardiac output. So light anesthesia is like giving norepinephrine. Now, one could say, let's give norepinephrine to raise blood pressure. And you'll see this in some studies. Having said all that, what I believe the benefits of norepinephrine to be, I think practically speaking, the chances of overdosage and getting yourself into a bad situation with systolics of over 200, because I've seen this happen, probably recommends phenylephrine or perhaps ephedrine, depending on where you're sitting blood pressure-wise, where you're sitting heart rate-wise, may be a better choice to do this. Now, the reason people are concerned about using light anesthesia is that there's a concern that you're going to have patients awake. To the extent that you have EEG monitoring, you can mitigate against that. The other thing in this study is that we saw more, not just increased end systolic wall stress, but more regional wall motion abnormalities in the patients who got phenylephrine. So here's a study that says phenylephrine is, but when you looked at MIs, there was no difference. So yes, that's where this comes from. Practically speaking, I think most people still give a fair amount of phenylephrine. A lot of it has to do with concerns about awareness. Now, in reality, since few people use either of these gases for carotids these days, it might be useful for someone to repeat this study with the modern halogenated anesthetics. Thank you.
Got one more question.
Sure.
So, what about cerebral protection with the volatile anesthetics? Do we have any recent data with newer agents?
Yeah, from the perspective of carotid endarterectomy, and this sort of regional cerebral protection, I can't speak to that. I don't know who does neuroanesthesia in here. Who's the neuroanesthesiologist du jour? No one wants to fess up? Okay. You know, it's not clear to me that we have a basis for choosing between gases in the setting of carotid endarterectomy. Do you have a perspective? Mm-hmm. They're mostly done by the vascular surgeons. Then that's typical. Question was, do we have any recent data on choice of volatiles and cerebral protection? Yeah. Yeah. I'm just not aware of any studies in carotids that compare the two. And most of the studies have been this comparing to TIVA kind of thing, looking at advantages of TIVA. Yes?
Maybe a related question. Any generated data on preconditioning to the pre or post-conditioning?
One would think so, and I know that people have looked at this sort of laboratory, but I'm not aware of people looking at this in the setting of carotid endarterectomy or angioplasty stenting. Yes?
One of the slides where they did the combined general, they had the ears on.
Yeah.
What role do you see those being, especially if you're using
Yeah,
ECG or...
we collected some data we never published on the NEERS some years ago, and the sense was that it was neither sensitive nor specific enough. The people at Michigan actually published data about this. I don't have a slide in here about it, that showed the sensitivity and specificity was just too low. That is, you could have patients with EEG changes. Now, I didn't show the data here. EEG, people have done studies looking at EEG in the awake patient, and the sensitivity of EEG in the awake patient is pretty high in terms of predicting. You can have, there's a subset of patients who will have neurologic changes without EEG changes, but it's pretty small. With the NEERS, however, you know, defining a 20% decrease as the standard, it wasn't sensitive enough. And so, you know, I'm sure there's someone who uses, you know, cerebral oximetry as their monitoring, as their sole monitoring device. But I don't think the literature suggests it's as good as EEG. So, I mean, you may tell me that that's what you do, but like I said, our experience, which we never published, the Michigan experience is that it's not sensitive enough today. You would be probably missing some aspects of ischemia that you can pick up with EEG, and the awake patient as well. So, and the problem is, you say, okay, fine, then rather than 20% decrease, we're going to take 10% decrease. We're going to make it more sensitive by saying we will shunt if there's a 10% decrease. Well, then what you end up doing is shunting a lot of people unnecessarily. You see, even with EEG, you shunt more people than with the awake patient. Okay? So that's the problem. Now you're going to shunt more people. And you can have complications of shunting. I have here, I got to review a manuscript for the Red Journal that describes a shunt complication with a patient who had an anomalous takeoff of you know, they're having the, I guess it was coming right off of the common carotid, they had their left coming off, okay? So and then they put a shunt down, then they ended up having ischemia on the right side because they got everything ischemic because of where the proximal part of the shunt was. So shunts, you know, shunts make you, from your perspective on this side of the screen, shunt makes you feel good, right? I think, maybe. You say, okay, fine, we got perfusion. But they have complications. They have bleeding complications. They prolong the operation. They have embolic complications. So they're not a free lunch. And so if you increase the amount of shunting, that's not necessarily good for patients. Yes?
Dan Sessler's published a lot about triple low
Right.
Recently.
Right.
And just thinking about cost and those sorts of things.
Right.
Do you think there's a future of just reducing EEG down to a BIS and being able to pick up if someone, if they're in that triple low state, that this would be a patient even more so you could pick it up in and we could get, guide things off something?
Okay, well, a couple of things. Number one, if you're going to do BIS monitoring, you need two devices. Okay, so one can argue that that's cheaper than having, full EEG monitoring, although you're not going to have the full array, so you will miss some regions of the brain. So that's not so much talking about Dan's triple low. That's just you got to use two BIS devices because you want to compare the two sides. Because again, you have. And these are people, they're going to end up in Dan's triple low people. These are, old people, and they're on ACE inhibitors and stuff like that, so their blood pressure goes up and then it goes down. And these patients roller coaster blood pressure. But you have to have both sides so that you can say, oh, this looks like ischemia compared to what we see over here. And it's not just a generalized anesthetic effect. So the triple low idea is that people who have low blood pressure, low volatile anesthetic requirements, and yet low BIS do worse. And you get into the whole discussion that Terry Monk brought up where she showed that people that had low BISs during surgery were more likely to be dead a year later. And then the question is that because they got too much anesthetic and were shown to be, and anesthetics are toxic, or is it that you've uncovered the bad brains, right? That by showing people who have a low BIS with a normal anesthetic, you've looked at people that got aged brains, bad brain. We know MAC goes down with age. Then what Dan has said in some of his work is that if you identify people with triple lows and then you treat them expeditiously, right, with most often, I think, phenylephrine, if you essentially rescue these patients from their low blood pressure despite low gas and low BIS, that you have hopefully better outcomes. I haven't read his work in about a year. It seemed to me that it was a little speculative to say, clearly identifying higher risk patients. It wasn't clear to me that the next link in that chain, which is to say we can do anything about that, it has been proven clear. Now, I don't know what your understanding is. So in the setting here of having these patients triple low, in general, my experience is that these patients, the hypotension is after reperfusion. And if you run these patients light, that hypotension is generally not so much of an issue during the first part of the procedure. So I'm not quite sure I'm answering your question, but I've talked around it. Is there anything you'd like for me to address more specifically, or?
It's just, it's like you said, it probably uncovers the bad brain, or maybe the brain that has lower reserve for hypoperfusion, and just think about with cost and other things, how if you have a full EEG versus even
Right.
two, a BIS on each hemisphere.
Right.
Is it possible to, or is anybody, did you know of anybody who's working on?
I don't know that anyone's looked at triple lows specifically in the carotid population. The other thing you have to remember is that, I don't know where it is where I showed you. Here we go. These patients who have EEG, these patients don't need a lot of anesthesia. Okay, so first of all, the MAC, for example, I said desk strain here. The MAC is low. Okay, this patient this patient has almost no desk strain on board, right? They had 7% nitrous. They got a block. They got a cc of fentanyl on board, and I'm talking to my, neurophysiologist. The patient's asleep. Okay, EEG. Now, one of the things that I have seen from doing this is that the EEG lags the end tidal. As we talk about the end tidal being what the brain sees, the reality is that there is a lag. And you see this here. So here it says basically there's no gas on board, but this patient is still anesthetized. One of the things I've done for teaching is after the carotid repair is complete is to demonstrate to a trainee what happens when you increase volatile anesthetics. Because we still got the EEG on. Okay, so we're going to increase the volatile anesthetic. This is teaching. Okay, increase the volatile anesthetic, watch burst suppression, occasionally silence the EEG within the limits of tolerable blood pressure. Okay? You've got to take care of the patient. And what you see here is you increase the volatile and the gas end tidal, boom, jumps up. The EEG lags. So this notion that the end tidal you're and you see this when you wake patients up all the time, right? That there's a lag between, the end tidal is not saying anything, and yet the patient's still not quite ready to wake up. So keep in mind, there's probably the brain is probably still seeing some anesthetic effect here.
All right. Thank you very much, John.
Thank you.